Today is the first session of our REACH series, and we welcome our speakers today. My name is Vanessa Vronsky, and I'll be your webinar manager and host. Today's webinar will last approximately 90 minutes, which includes time for Q&A and an interactive discussion. All of the resources, webinar slides, and the recording will be shared with everybody who's registered for today. Microphones will be muted during the presentation at designated times. For example, during our Q&A and panel discussions, you can request an open mic via the chat box, or you can raise your hand. When speaking, be sure to use strengths-based language and also to eliminate background noise by muting your microphone when not speaking. Registration affirms your consent to recording. If you experience any technical issues, please send me a direct message via the chat box. This presentation is offered by the New England MHTTC, and the opinions expressed are those of New England MHTTC and not SAMHSA. The MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. Please make sure you do the same as you interact with us today. We're pleased you joined the webinar, and I now turn the session over to Maria E. Restrepo-Toro, the co-director of the New England Mental Health Technology Transfer Center. Thank you.
Thank you so much, Vanessa, and good morning, everybody. Welcome. My name is Maria Restrepo-Toro, and I am the co-director of the New England Mental Health TTC. I work, our director, Dr. Lyra Davidson, directs the center, and we have three amazing partners in this effort, C4 Innovations, Harvard Department of Psychiatry, and the Center for Educational Improvement. Let's look at our agenda today. We are absolutely delighted that you have joined us for today's meeting. Could we advance to the next one, please? Thank you. What we're going to do, we are absolutely extremely lucky to be joined by remarkable speakers today. We are going to be hearing at the previous slide before. We are going to be hearing from our assistant regional director. She's going to give us, and I may do a better introduction when I get to that. Then we're going to do talking about the why. Why are we doing this REACH initiative in New England and the importance of this? Then turn it over to understanding our mindset with Dr. Jessica Isom from Yale University. And of course, we are honored to be joined by the director, Dr. Mary Roary, who is the director of the Office of Behavioral Health and Equity at the U.S. Department of Health Services and SAMHSA. So with that further ado, I want to turn it over to our opening remarks. And let me just introduce you. I'm sorry, the next slide, please. We would like for you to connect us through this work. I was ready to introduce Dr. Taylor Riley Turner. She is our assistant regional administrator here in Region 1. She comes to the region with over 20 years of experience, strategically advancing public policy, and she's a steady advocate for vulnerable populations. Her role is invaluable in our region, and she has really elevated the work of community-based work organizations, especially those that are really to support the BIPOC populations in New England. So with that, it's my pleasure to introduce Taylor.
Thank you very much, Maria, and I understand the technical issues. I cannot wait to be in person with all of you. It's been a joy and honor to work with you over this last year and a half or so. So good afternoon and welcome to this community critical dialogue today. My name is Taylor Bryan Turner, and I'm the Assistant Regional Administrator for SAMHSA's New England Region, Substance Abuse and Mental Health Services Administration, and I'm honored to be with you and invited by the New England MHTTC as part of this movement of inclusion. Since I began at SAMHSA, race and inequality and how they are magnified in this multi-layered syndemic have been a part of every conversation regarding opioid misuse, overdose, alcohol, youth mental health, COVID-19, exposure and vaccine mistrust among BIPOC populations, maternal health, access to treatment, criminal justice and restoration, you name it. It has been raised enough to know that we cannot sit back and obscure this data under a subcategory that isn't spoken about or doesn't make the presentation, right? These disparities are in 3D. And at SAMHSA, we have an entire division, the Office of Behavioral Health Equity, that is laser focused on changing the narrative on these disparities that will be laid out before you today by the dedicated and passionate director, Dr. Mary Roary. I am delighted that she could be with us today. The Office of Behavioral Health Equity works to improve the disparity impact statement, works to elevate community-based organization, and leads and partners with the National Network to Eliminate Disparities Network to amplify and produce technical assistance and training opportunities. OB has worked extensively with us in Region 1 to raise the Diversity Inclusion Project Showcase to a national level, which seeks to champion community-based organizations that serve historically marginalized populations and position them face-to-face with funders for an opportunity to equitably serve their communities. The New England MHTTC's REACH component that you'll hear more about today really complements those goals beautifully. Some of the work that has come out of OB, next slide please, has some really powerful quotes that are shared here today. COVID-19 pandemic, economic crisis, and widespread racially focused protests has highlighted glaring inequities for racial and ethnic minority communities. These crises have magnified, has significant implications for mental health and exacerbate already poor access to behavioral health services in BIPOC communities. And this work is evident and important and really works in tandem with the Diversity Inclusion Project Showcase. Today's lineup is unbelievably sharp and intentional about securing data and using it to its fullest utility. But we recognize that there are gaps in the data, and the data doesn't quite capture the oppression, inherent trauma, intergenerational trauma, historic racist systems, or public-facing jobs that we have been fraught with, congregate housing, which is sometimes a vector for diseases like COVID-19, and the inability to work from home for many diverse populations, right? It's hard to capture the pain and the trauma that some of these families and hardships go through. Today's presentation is a smattering of what will continue in the coming months as we work together to build our knowledge, resolve, and resilience for us and the people that we serve. Hopefully, these topics will become second nature, and we can have these conversations more candidly, more naturally, and intentionally. So as we begin, I'd like to leave you with a quote from Oprah. Yes, I said Oprah. She says, "Because what I know for sure is that everything that has happened to you was also happening for you. And all that time, in all of those moments, you were building strength. Strength times strength times strength equals power. And what happened to you can be your power," right? So during these moments of connection, I implore you to think about how we can use our cultural awareness and our personal power to change the outcomes of those we live to serve. So I'd like to thank co-director Maria Restrepo-Toro and Ingrid Padgett for inviting SAMHSA and Tim Jean as well to be part of this conversation today. And I'd like to turn the agenda back over to Maria Restrepo-Toro to get started. Thank you so much.
Thank you so much, Celia, for that amazing welcoming. And I think just very briefly, I want to tell you about why is this initiative so important for the New England Mental Health ETC. As you know, we are one of the 10 regional centers in the country, and we have been funded for the last 4 years. I'm very happy to do a lot of work in many different areas, but this one is very close to our heart. So probably if you can turn it to the next one, Janan, thank you. We decided that we're totally invested, and what I mean is everybody on our staff is invested in advancing really equity within the region. We are committed as an organization to advance health equity throughout the state so everybody can recover and be actually included in the community. So we created this initiative called Better Together. And in that initiative, we're going to be doing multiple ideas, including multiple things, including inviting all of you, because we're in all of this together, and we want to be able to create a community where we can all learn together. So why then are we doing this, and how we're going to propose this today? This is just day number 1, and we're going to be here doing this work for years to come. As we know, this work takes a long time, but it takes a lot of champions. So the next slide, and briefly, we want to understand a little bit where you're coming from, but when we do this kind of work, next slide, please. It's really important to understand for us that our center, our New England Mental Health TTC, is focused on resilience and recovery. We are all about promoting wellness principles and having and helping people really live successful life. Okay, so we are here invested in these principles. And with that, we also want to, in addition to disseminating all the evidence-based practices in the region, we want to make sure that all the people that request our services are going to be really asking about different communities of color. So for us, the why is really important because we believe in cultural humility. We believe that our stories can connect us. And we understand that knowing the data is important, because in order for us, if we don't know what we don't know, then we need to understand how then we move forward together in this agenda about racial equity and cultural humility. Janan, because our stories connect us, I'm going to ask you to please just do a little bit so we can have a sense very quickly via chat who is in the room with us today.
Sure. Vanessa, if you could go to the next slide. Okie dokie. So I think things were changed a little bit around, but that's okay. At this time, we'll just ask the participants to introduce yourselves via the chat, who you are and where you're coming from. If you could also let us know why you joined our seminar today and what's one thing that you hope to gain as a part of today's session. That would be really helpful so we have a sense of who is sharing space with us and have a sense of what folks are coming in hoping to learn. Again, your name, where you're coming from, why you joined today's seminar, as well as what you hope to gain from today's session. Thank you, everyone who's filling in the chat. We have folks from all over, Connecticut, Massachusetts. Rita's joining from Michigan. Welcome.
And shall we turn it back over to Maria to get us started?
It is my pleasure, and you are going to be getting this presentation. I want to make sure everybody gets a chance to hear this amazing day today. So it is my honor to introduce Dr. Jessica Isom. She is an attending psychiatrist at the Conman Square Health Center and a clinical instructor at Yale University. While completing her medical residence at Yale, Dr. Isom was a chief of medical education as well as a chief resident of diversity and inclusion. Dr. Isom's primary interests in mental health are working towards eradicating racial and ethnic mental health disparities, mitigating the impact of implicit racial bias, and the use of a community-focused population health approach in psychiatric practice. So Dr. Isom, please welcome to our session to get us started in this amazing effort.
Yes, thank you, Maria. And hey, everyone here. I'm going to take about 15 minutes or so to have a conversation about mindset, which I'm really actually excited to start off this conversation because we often talk about the work as far as what to do and don't often spend a lot of time interrogating what has produced inaction in the face of need before that decision. And a lot of that has to do with our racial ideology, the way that we understand race and our relationship with it, but also our mindset towards it as well. So on the next slide, I've detailed for you the two parts that we'll be focusing on. The first is talking about the power of a mindset. And this image on the right is from an article that was written by Robin DiAngelo talking about an investment in racial illiteracy for white people specifically. And I like the image because it basically puts us right in the place where I'd like us to be, which is thinking about how we think and how we think, how we feel informs what we do, how we behave, which I think is a very familiar concept to all of us. But beyond us at the individual level, all of this thinking and feeling has translated into how structures have been constructed as well. So we'll talk about that. And then I'll secondarily introduce you to this concept of equity mindedness from the Center for Urban Education that I've grown to be really attached to and have found it useful for having conversations with an audience like you, but also encouraging you to have conversations with others. So let's get started with part one. This first part is essentially just offering you all some ways of thinking about what mindset means. So I've included some definitions here to get your juices flowing. The first is that a mindset is an established set of attitudes held by someone. And attitudes are often not just thoughts, but also very much connected to emotions, to affect. Another way of describing it is that it's a fixed mental attitude or disposition that predetermines a person's responses to and interpretations of situations. So it shapes how we respond, interpret, but also how we behave. And lastly, it's a set of beliefs that shape how you make sense of the world and yourself. And very much connected with what we do around racial disparities is how we think about how we are positioned and what that means or doesn't mean, and also about how others are positioned in whatever context. So what I wanted to talk with you about on the next slide is thinking through some of the ways that we have these kinds of conversations that suggest a mindset that may not be appreciable on the surface. So I've given presentations about equality and equity and justice and those sorts of things over the years. And this here is an image that I used often early on in presentations and thought it was a great image. I mean, it shows equality versus equity. Oftentimes you'll see underneath the pictures a description of what these mean. So equality visually represented is giving everyone the same thing, and equity visually represented is giving people what they need. What I'd like you to do before I continue talking is just to take about 15 seconds to look at the image and think about what the image is actually communicating to us, both in obvious ways and in subtle ways. So I'm going to start my timer for 15 seconds and then I'll start speaking in just a moment. So take your time. All right. So in this image, you see three people standing. There are some differences between these people that would be important for us to recognize. But the main difference that they're intending for you to focus on is how the resources in this image are distributed for these individuals to see over the fence. As you're thinking about the picture, though, I'd like you to focus on the individuals, including on the next slide, as they have a discussion about reality and liberation. So in the reality picture, the biggest difference between equity and reality is that there's more of an environmental focus in the reality picture, and that it's not just the boxes, but there's also a person in a whole. And that is a step towards acknowledging context, which we'll talk about in just a moment. But lastly, they also reference in this image liberation, where we are not just focusing on the symptoms of oppression, but actually addressing the roots. And addressing the roots would be removing the fence entirely, or providing, if another articulation of this, removing what would require us to offer equitable interventions in the first place. One of the things that I came across last year was an article in Academic Medicine. And if you switch to the next slide, again, the part of the image I want you to focus on are the people. When I came across this new image, which I'll show you in just a moment, I was like, oh my God, I get it now. This is a part of what people may not be appreciating from looking at this. And my thinking about this changed when I saw an article that it actually compared a number of different representations of this, from people on bikes or other like assistive mobility devices, or people in other scenarios, having or showing what it means to be receiving equality versus equity. If you look at the people though, what I hope that you are able to appreciate is that the people themselves are different. There's a taller person, a medium stature person, and a shorter person. And if you think about racial ideology, the belief system that we've been indoctrinated into from birth, one of the core aspects of that is a belief in inherent racial differences that are rooted in biology. So there's something inherent, natural, characteristic about these different racial groups, and that produces often conversations around their deficits for some groups and strengths for others. And the interesting thing about this picture is that there are differences here that are technically biological, and stature is produced by your genetics. And what this is saying on the surface is that, yes, there's a focus on equity is needed, but it's also subtly communicating that the equity focus is needed because there's something naturally deficient about certain groups that requires additional support. So on the next slide, this is just a really, really nice paper from academic psychiatry. It's entitled Race, Metaphor, and Myth in Academic Medicine. And they critiqued these images and started a conversation in their article about, well, what are we communicating? What are the myths that we're perpetuating in our conversations? And how can we shift to something different? So what you'll notice in this image is that everyone is similarly fashioned. They're all the same stature, wearing the same clothes, but the difference here, the focus of the difference here is on their context. So you have some people on boxes looking over the fence, you have others in holes, and you have others in chains. And if you think about the kind of conversations that we have about what does equity mean for the populations that we're working with, you probably will notice that there's sometimes an overwhelming individual focus on what people should do. And then other times there's more of a structure focus on how things should be changed to lead to the justice and liberation that we talk about in these conversations. So if you want a conversational piece, if you want a thought exercise for people to walk through in the spaces that you're in, using these images can be a really helpful way of doing that. So with that, I will transition to part two. And part two is focused on talking about equity mindedness. And this is pulled from the Center for Urban Education. I was looking at their materials to think about how to support teachers in interacting with learners in the classroom in an equity focused way. So I took that and kind of tweaked it a bit to be more broadly applicable to us, for example, as mental health professionals. So in order for us to properly address racial inequities, we've already talked about the lens that has to be interrogated, but there are also very dominant cultural norms that really are barriers to engaging in the work. And I've listed a few of them here. One is race denial, also known as colorblind racial ideology, but colorblind as a term is an ableist term. So I use race denial along with others. There's also race silence. We don't talk about race just as much as we don't see it. And then there's that racial illiteracy, an investment in not really being able to understand race or racism, and oftentimes coupled with a disproportionately high confidence that you do understand race and racism. Which is all produced by your socialization. So in an equity mindedness space, the things that you would be looking for are that people are adopting a racial consciousness, that they are committed to an awareness of understanding how language and behaviors negatively impact racially, ethnically minoritized and marginalized people around them. They're also willing to see themselves as being complicit and as holding some power and influence, and using that to actually eliminate inequities by taking that responsibility head on. And then lastly, they're invested in understanding at a structural level, what are the things that are happening around me that are contributing to these inequities. So I wanted to first give you a sense of what this looks like when it's not present. So I'll describe that for you and give you an example of how that might look if it was you or a colleague. And then I'll describe what it looks like when it is present before closing out. So on the next slide, if you're thinking, how do I detect around me an equity, a lack of equity mindedness, what kind of things would I notice or would you notice? So an individual or maybe even an institution would claim not to see race. They wouldn't really see the value in disaggregated data. And a part of that is communicated by what they invest their resources in as far as the collection of data. And you'd be very surprised, or maybe not, what places don't disaggregate data, even if they have a stated explicit commitment to addressing racial and ethnic inequities. There's a disconnect there because it's a cultural norm to not disaggregate. Number three, this person or institution, they're unable to notice racialized consequences of things just being the way that they are, or they might say, you know, it's not race, it's actually something else. They also don't really view racial equity as a personal or institutional responsibility, and they view the workplace in the clinical setting as just a space. There's no race or racism relevance here. So I want to introduce you to a person, Hannah, and just describe for you what this might look like in real life on the next slide. So Hannah is a psychologist working at the State University Medical Center. She struggled with the increased focus on race and racism during the past few months, and she shared with others how terribly inappropriate it is to keep mentioning race. When asked to look at the inpatient team's referral patterns, she reacted strongly to the suggestion that the data be disaggregated by race, stating, "This is not something we can let happen. Race is not more relevant than education or class. Those are the social determinants that matter most, and we are going to end up missing the mark here." She's also shared references with team members that sidestep the mention of race and instead focus on class as the primary determinant of health status in hopes of changing the conversation when racial equity comes up. Hannah hasn't found the focus on individuals fixing racial inequity useful, as she feels the responsibility for health lies with policymakers and patients. She has offered repeatedly in conversations comments that suggest the workplace is not one where discrimination happens very often, thus making a focus on medical racism a misguided one. So I'll ask, if you want to drop in the chat, are you a Hannah or do you know any Hannahs? And we'll talk more about that later. So transitioning to the next slide, what would it look like if equity mindedness was present as an individual or within an institution? Well, people are committed to an awareness of their racial identity, what that means for them, what it means for others and their interactions with them. They're using disaggregated data all the time as a norm to identify racialized patterns of outcomes. They're also constantly reflecting on what does the status quo mean as far as how it might reduce racial inequities or perpetuate them. And then they're also really thinking about what is my agency and how does that relate to the work of getting us towards racial equity. And lastly, the workplace and the clinical setting, just like any other place, is a racialized space. They understand that, and they're actively monitoring themselves and interactions with racialized minorities. So let's meet Damien. Damien is a new member of an anti-racism work group anywhere and has found the experience to be rewarding. He has long considered the relevance of race to neurologic practice and had been hoping for a more collective focus for most of his career. Now as an attending, the boss on the team, he's been able to drive team conversations in ways that account for how multi-level racism shapes patient experiences. He emphasizes the importance of looking at the bigger picture data while also nailing down how different racial ethnic groups might be experiencing the issue. His team members are appreciative of his efforts to invite curiosity on the status quo, manifesting in policy and practice. And that is a very pie in the sky, idealistic response to his efforts, but we're going for a hopeful narrative here. He has been open about his commitment to personally intervening in whatever ways he can to achieve equity. His most recent focus has been on helping his team to understand how racism shows up in the workplace. And to support this focus, he has been reading more about how to encourage a self-reflective practice that acknowledges how race colors interpersonal interactions and institutional behaviors. So go, Damien. And I'd also be curious to know if there's any Damiens out there or if you've come across any Damiens in your different workplaces. So closing out on the next slide, just to highlight, it is important that with this equity mindedness framework that you understand that it's not just at the individual or interpersonal level. There are other levels to this as well, including at the institutional organizational level, the community level, and the systemic level. And for anyone who's curious about where could I go to get a better appreciation for this, a really great toolkit is from Reji, R-E-J-I. You can find it really easily online and it's free to download. And they really do a great job of breaking down these different levels. The reason why understanding these levels are important is because, and also why having this mindedness is essential, is that when you look at the image on the next slide, you'll have less of a defensive reaction to how this is constructed. So yes, we know economics, the neighborhood, the environment, education, food, your community context, and the healthcare system shape all of the outcomes that you see there in orange. However, the acceptance that racism and discrimination shape the shaping of those health outcomes is something that people develop a lot of defensives around. So this equity mindedness approach can in some ways help you bypass, or at least do that initial work before you get to an image like this, because that will allow you to approach this image in a way that's equity minded, that helps you to define the problems in a different kind of way that generate better solutions. And those solutions often are around not blaming the individual and more so acknowledging how structures impact individuals. So with that, I will end with a quote from James Baldwin, one of my favorites, on the next slide. It is certain in any case that ignorance allied with power is the most ferocious enemy justice can have. And if I'm anti-anything, I'm anti-ignorance. And I hope you can join me in that as well, by absorbing this for yourself, but also sharing it with others. So with that, I will pass it back to Maria. Thank you.
Wow. Thank you, Dr. Isom. This is a lot to question. And I think at this point, let's move on to the next question. We're going to stop for a moment. I think your question is so interesting. This is something definitely our effort is going to be working moving forward with the organizations that we're going to be do. What is your equity-minded question? So we want to do a little bit of a discussion around that, and just want to hear about it. People, I guess, would you want to hear people to unmute or just via chat? It's probably easiest.
Yeah, it would be helpful to hear from some people in the chat, about their exposures to a quotient that's very low, not much equity mindedness, versus one that's very high. And what that has been like for you as you're trying to engage in this work yourselves. And I can
people
say
can raise their hands, and I'm sure we can let them in that way. It doesn't get too complicated. We have a lot of people, so thank you.
I think it would be helpful too if some of our panelists could also speak to some of the things that Jessica shared relative to kind of, the reluctance around knowing the data, ways to consider the social determinants of health.
I'll go first. So number one, awesome. Dr. Isom, that was awesome. I feel like I'm in school. What I want to say, and will allow everybody else to join in, is if it's not there, create it.
That's a drop the mic moment, I think. And I love to hear from others about what creating that would look like. But my hope is that one of an examination of the image could be one example of an exercise that might facilitate that transition from it being absent to it being present.
I'll jump in. I don't have a drop the mic moment, but I would say make awkward, turn away from awkwardness and start to amplify, right? What I saw in the pictures that you showed was equality as a concept, but equity is the intentional action behind it. And I think there might be some stigma to that, not stepping forward. Everyone is thinking the same things and want the same things, but who's going to be bold enough to step out and elevate these issues in your workplace?
Yeah, Taylor, and there's this concept that some of us live and breathe, but people give it a name and it's like, oh, that describes it. Someone was talking about challenger culture recently. And most people, if not all, who are invested in doing equity work are challengers, and they have to navigate what it means to be in that role as a person who shakes things up or shakes tables or addresses the status quo, and often has to face a lot of resistance from others. And it might be helpful to talk for a few minutes around how is it that we decide to be the challenger despite facing so many challenges from others around the things that we're suggesting would be really helpful. And I could speak for myself and say that one thing that helps me be a challenger is to adopt a teacher's role or educational stance, which just acknowledges that people are on a journey. That journey has a starting point, and hopefully the ending point is closer, to where I would like them to be, to join me in doing the work together. And that can help me a lot of times be a bit more patient, just a bit, and to leverage like an educational kind of exchange as one where people may feel a bit more comfortable versus one that's more confrontational. These are the things that you need to do, and this is why you're not doing them, which can often make people more resistant. But curious about what you all think about.
I'll speak up. I never, 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 ever give up. I don't go away. I have that fire in my belly and I refuse no.
Thank you, everybody, for the comments. And I think that's exactly what we have created this community. And that's exactly how the New England Mental Health TTC feels about this. We're here to create change. We are here to create action. And that's what we are here to do it together, because I also hear that it's so important, and we have to start with our own mindsets, but we need to really work at it and just be action oriented. So I'm mindful of the time, and I want to make sure that we can continue our conversation. So I think now, actually, Dr. Roy, you are the next speaker, but I'm going to turn it over to Taylor, who's going to have the honor to introduce you.
Thank you, Maria. It is an honor. Thank you very much for the privilege of introducing Dr. Roary to the virtual stage. Dr. Roary has elevated the playing field for diversity, equity, and inclusion at SAMHSA since she's began. She spearheads several working groups and is highly sought after by her colleagues and a Region 1 champion in our efforts here to end disparities in mental health spaces. She has become a mentor and a play auntie for me. But Dr. Roary is a public health epidemiologist who specializes in infectious and chronic diseases. Dr. Roary is currently the Director of Office of Behavioral Health Equity at the U.S. Department of Health and Human Services, Substance Abuse and Mental Health Services Administration. She is also an adjunct professor at the Catholic University of America. She received her undergraduate from Morgan State University, several master's degrees from Johns Hopkins University, and her doctorate from the University of Arizona, where she was an epidemiologist and biostatistics CDC fellow. We're in luck. She is a data diva, and we are so fortunate that she could make time to be with us today. Thank you so much, Dr. Roary.
Wow. I hope I can live up to all that stuff you just talked about. But here's the first thing I want us to do. I want to take 30 seconds to honor all the people that we lost this year. We have got to take care of ourselves in this mental health space. So we're going to take 30 seconds to pause for self-care and to honor the folks that we lost to COVID-19, the civil unrest. We just want to pause here. Thank you. So you all are at the right place at the right time. The second thing I want to do is go bravo. Thank you for all the work that you do every day, that you put up with the racism and the discrimination and the unfairness. No, I can't get this. No, I can't do that. I want to thank you all for all that you do. I want to give a big thanks, before I forget to do so, to Maria, to Ingrid, to Vanessa, to Jessica, to Taylor, and Tim. I feel honored to just even share a stage with them. Equity has gained so much attention lately because it is the absolute right thing to do. COVID-19, the ongoing civil unrest, exposed it even further. The presidential executive orders on January 20th, 2021, there was an executive order 13985 on advancing racial equity and support for underserved communities through the federal government. And this is when our life exploded at the Office of Behavioral Health Equity. Now, and the list goes on, but here's my challenge to you all. Here's your call to action today. You're already doing it, but don't stop doing it. Regardless of the pushback, keep moving forward. And when that fire in your belly runs out, you pass that baton on to someone else so that we can keep this going. So I challenge you all to eat, think, and sleep equity so that the behavioral health conditions of the nation not only is improved, but sustained. It will indeed take all of us to pull our talents and resources together to get America behaviorally healthy again. We cannot be afraid to ask those tough questions. So thank you, Jessica, for raising all the valid points you raised. My job here today is really simple. I want you to not be afraid of the data. So we need data. So it's nice to say that, oh, I saved such and such from suicide, or I prevented this. That's all well and good, but it is more powerful if we have the data. So if you leave here today with nothing else, don't forget what Jessica said to you. Don't forget what Maria said to you. Don't forget what Tim will say to you. Don't forget what Ingrid has said. Don't forget anything, but don't forget this for me. Don't be afraid of the data. The data is more than bean counts, and we're going to get into that. All right, so why equity, why now? Well, so about behavioral health equity, what is it? Why do we even care? The absence of disparities or avoidable differences among social, economic, and demographic groups or geographical areas in health status, health outcomes such as disease, disability, and mortality. And I'm going to add behavioral health to that definition. That every person has the opportunity to achieve optimal health regardless of the color of their skin, level of education, gender identity, sexual orientation, the job that they have, the neighborhood they live in, or whether or not they have a disability. Why is this all important? I'm glad you all asked. Persistent racial and ethnic health disparities can be largely attributed to poor social and physical determinants of health in these communities. Advancing behavioral health equity and health equity requires a multifactorial response to address issues such as high unemployment, inadequate housing, lack of quality education, inability to access healthcare. Reducing health disparities also requires solutions that are informed by and tailored to specific racial, ethnic, socioeconomic, and geographical communities. I know you're saying, why is this all important? I'm getting to the data in a second. Prevention is key to good public health and maintenance. Best practices to reach under-resourced populations or disparate populations is go where they are and approach them in a culturally relevant, sensitive, empathetic manner, because without behavioral health, there is no health. In order to prevent substance use and mental health issues, we must prevent it in the first place. And if we fail, there is treatment, recovery, and relapse, which should be offered over the lifespan. In other words, I need all of us to continue, because I know y'all are already doing this. We're going to share it with the people who have it. Culturally target your target population, and then together we will get there together. Now the data. What's really fabulous about SAMHSA? First slide, please. Thank you. What's really fabulous about SAMHSA is the Center for Behavioral Health Statistics and Quality, also passionately known as CBIS. CBIS is the lead federal government agency for behavioral health data and dissemination in the United States. We hope we're having an impact on an international community as well. CBIS provides statistical and analytical expertise to support the Assistant Secretary for Mental Health and Substance Use and the Secretary of HHS. CBIS data collection is mandated, right? And in December 2016, per the 21st Century Cures Act, it was signed into law. So CBIS is not going anywhere. Now that's so wonderful, right? So what else? CBIS has a very popular, very well-known, I'm hoping to you all, and after this session, you will definitely know about it. It's the National Survey on Drug Use and Health. It's called the NISTA, that's the nickname. But CBIS also has a ton of other surveys that you all should become familiar with. Drug Abuse Warning Network, SAMHSA's Performance Accountability and Reporting System. They have all types of data. The Mental Health Service Survey, tons of data. I encourage you all to go to the website, which I'll drop in the link. Don't worry about looking for it, to make sure you visit the data. Now, this data is super important, but also the Census Bureau, also the National Center for Health Statistics data, Center for Disease Control. I can go on. Data is important. Now, what's really important about it is that it's available. You don't even have to download it or crunch it or analyze it or clean it. It's done for you. You can find out what's going on in your communities. I implore you to use the data. What does this mean? This means a stronger grant application. You'll score higher. What does that mean? Why is that important? You'll be able to reach the people that you would not ordinarily be able to reach. You'll be able to help the mom and pop community-based organizations who need your help, who need to partner with you to make a difference. In SAMHSA, right now, we have data for 2019 and 2020. I'm going to let Tim Jean walk you all through it, but here's what I'm going to say to you. At the SAMHSA, the NISTA data is critical because it tells you a picture of the state of the mental health and substance use disorders across the country. It's powerful. Here you can see large numbers, but here's what I challenge you all to see also. What's not on this screen? Everybody is not filling out a survey. So can you imagine how worse this picture is? Can you imagine what is going to happen if we all stop working today, right? So here you have on this slide in 2019, and we'll share this, but we'll also share the next slide, not yet, but thank you, how important this data is. It gives you a snapshot of what's going on. In 2019, we had people aged 18 and older who had a substance use disorder. We called it 19.3 million, but I want you all to go with me on this. It's probably much higher. Think about the underreporting. Think about the stigma. Think about the stereotyping. Think about, I'm going to lose my job. Think about that. In addition, we see we have 51.5 million people aged 18 and older who had a mental illness. Now go with me. 9.5 million combined substance use disorders and mental illness. People 18 age and older represents almost 10 million people of the population. Here again, I guarantee you that number is slightly larger. So in 2019, 61.2 million Americans had a mental illness and or substance use disorder, which is an increase of almost 6% over our 2018 data, composed entirely of increases in, watch what I say, mental illness. But there's gaps, there's treatment gaps. And what I'm about to show you on the next two slides is that there's huge treatment gaps for all of us. Amplified and highlighted here is going to be the African Americans and the Hispanics. Basically, what you're going to see is that these slides will mirror, but just hold tight. So for substance use disorder, and I said age 12 and older, and it breaks my heart to share this with you, 12 and older substance use disorder. Again, imagine if you're living in a religious, say, household. Did you get to give input into the survey? I'm not sure that you did. But here you'll see that out of the 2.4 million, only 90% is not receiving treatment. So we got a problem here. You'll see the trend continues. Any mental illness, ages 18 and over, right? 5.2 million. Well, 67% who are African Americans are not receiving treatment. If we look at serious mental illness, 1.2 million, but 42% that responded that they're African Americans are not receiving any treatment, none. Can you imagine? 91.5%, no treatment for co-occurring. This means you got substance use issues and any mental health illness in ages 18 and old. Major depressive episode, here we go again, in ages 12 to 17. Now, it breaks my heart because this is our future. These are the folks that's going to go to school, to medical school and wherever else and take care of us. So we got to ensure we cannot stop this work because they are our future. They're going to take care of us. And surely we want them set up better than what they are right now. Again, African American, no treatment. 65% no treatment. It's unacceptable. There is no difference for my Hispanic, Latino ex-sisters and brothers. No difference. You see the same patterns. Substance use disorder, 12 and older, 92, almost 92% not receiving any treatment if they said that they were Hispanic. No treatment. Any mental illness, 66% not receiving any treatment, none. Serious mental illness, almost 50% not receiving treatment if they identify as Hispanic. 94% not receiving any treatment if they have both a substance use disorder and any major illnesses, mental illnesses, 18 and older. Major depressive symptoms, 63%. Now, the problem with this is 2019. Can you imagine what 2020 looks like? Now, I'm going to pause here because I want to read you something about both of these. Again, the data from 2018, 19, and 20 shows us disparities of treatment gaps for substance use disorder, any mental illness, serious mental illness, major depressive episodes, and can get even worse if you have a co-occurring mental illness and substance use disorder, and you are African American or Hispanic, and you do not have equitable access to equitable care, you are afraid to share your trauma and your story because of the stigma, and you have a job that increases your risk for COVID-19, and you may be a young Black man who has a fear on a daily basis of police brutality. And if you're Hispanic, English is not your first language. We have a problem. So here's the take home. So the data will drive the policy, and the policy will drive increased and needed funding that will drive sustainable change on the ground. If you remember nothing else, please don't forget about the importance of the data. It's nice to say that you've made a difference. It's even more powerful when you have collected, tracked, cleaned, analyzed, published, and disseminated the data and its findings and the next steps, also known as a call to action, in an acceptable, accessible format for all to understand, from the affected participants to the White House. Everybody needs access to this data so that they can understand how to empower and how to make a difference. This will not go away without all of you. Next slide, please. So I've shared this and I've jumped ahead, but I also want to highlight very quickly that the data has also increased. Thank you so much. And that the missing data that you may see, well, I'm blaming everything on COVID-19, but also that the data will soon be available. Right now at CBIS, they're working very hard to come out with a disparities report that will target all these target populations. It'll be coming out in 2022. Also want to make a quick reference that social determinants of health also plays to, so we say that we see these differences. Some of these differences are definitely because of where we're born, where we live, where we learn, where we work, where we play, where we pray, can also affect our economic stability, our education and access to quality, healthcare to access and quality, behavioral health care access and quality, neighborhood, built environment, social and community context. I can go on. Dr. Jessica covered it. We understand the connection here. So we can, you think about the data that you all are collecting. Say you're collecting race and ethnicity and age. That's nice. Think about tying in the social determinants of health and the role of cultural and behavioral health. Next slide, please. Again, we've covered this. Next slide. All right, Tim Jean, you're up.
Thank you, Dr. Roary, and hello, everyone. I just want to take a moment to fill the gaps for the other subcommunities that we haven't touched on. Here's a brief snapshot of mental health data for Asian Americans and Pacific Islanders. Among all of the AAPI population as of 2018, in the past year alone, nearly 3 million people reported having a mental illness. And over the last decade, reported serious mental illness nearly doubled from about 3% to 5.6% among young adults ages 18 to 25 years old, an increase from just over 3% to 5% for adults ages 26 to 49. Within this population of AAPI, major depressive episodes increased from 10% to 13.6% among youth ages 12 to 17, and just about 9% to just over 10% in young adults 18 to 25, and 3% to 5% in adults ages 26 to 49 for a 3-year period from 2015 to 2018. Suicide and suicide ideation is obviously a growing concern in the US, especially among people of color. In 2018, just over 8% of Asian Americans and Pacific Islanders ages 18 to 25 had serious thoughts of suicide, and 2.2% of them made a plan to carry that out. I mean, both of these figures obviously have increased in the last decade. Additionally, we're continuing to see an increase in binge drinking, cigarette smoking, and marijuana use, along with illicit drug use and prescription pain reliever misuse among AAPI adults with mental illness. Next slide, please. All right. And now taking a look at some data for Native and Indigenous populations. Mental health and serious psychological distress is more prevalent by 2.5 times the general US population in any given month. And we know that this has only been exacerbated by the pandemic. Although suicide rates among Native and Indigenous populations is overall similar to those compared to the white population, there are significant differences among certain age groups. Notably, Native youth and young adults ages 15 to 19 years old are more than 2 times likely to commit suicide than their non-Hispanic white counterparts. Additionally, Native people typically start to use and abuse substances at younger ages and at higher rates than any other ethnic group. The infographic to the right clearly outlines the urgent issue of mental health among Native and Indigenous communities, with just about 20% or 827,000 people reporting a mental illness last year. Next slide, please. And I want to touch on some of the trends of mental illness here in New England. And just to clarify that any mental illness is defined as having a diagnosable mental, behavioral, or emotional disorder other than a developmental or substance use disorder. Here we can see that in New England, past year reported mental illness from the NISDA reports in 2018 and 19, 4 out of the 6 New England states had between 100 and 200,000 people report that they had a mental illness, while Connecticut had over 500,000 and Massachusetts just under 1.2 million folks with a mental illness. Something to note here is that in each New England state, adults over the age of 26 reported having a mental illness significantly more than the youth counterparts ages 18 to 25. And although, as most of us are aware that there needs to be better service access across the board for people with mental illness, the latest New England regional data suggests that about 51% of respondents received service care in the past year. That's 8% higher here in the region compared to the national average. But as Dr. Roary did touch on before me, there are still huge treatment gaps, especially people of color dealing with mental illness. I think it's going to go back to Ingrid.
Thank you, Dr. Roary, as well. It's my pleasure to have this opportunity to kind of facilitate a conversation, really. And you can go to the next slide, actually next 2 slides, Vanessa. I'd like us to kind of think about ways to support the behavioral health needs of BIPOC individuals and communities. Now that we've kind of had a conversation, we've had some learning from Dr. Isom, we've had some data points from Dr. Roary and also from Tim. Thank you all. I kind of tend to think about this in kind of a 3 Ps. So how are our policies supporting equity and inclusion? How are our partnerships helping to support behavioral health needs of BIPOC communities? And even in terms of our philanthropy in workspaces and workplaces, what are the things that we can do? How are we able to consider how we might even be operationalizing racism? So it's a big rock, but I'd like for our panelists to kind of weigh in on that and have a conversation around it.
It's a big rock that we're going to roll right over top of. That's what the first thing I'll say.
I knew that.
We're going to roll over top of it. So let me give you one example that we think that is pretty impactful at SAMHSA. Right now, we're requiring that our grantees fill out a disparities impact statement. Now, this work was mandated back in 2011, but now President Biden has brought it back to life and saying that we have to. And so SAMHSA, I'm very proud to say SAMHSA was the first one to come out with a disparities impact statement. And we're currently working on a disparities impact statement 2.0. But this statement, if you will, that's required by grantees is using program performance data, and Dr. Isom will be proud of us, disaggregated by race, ethnicity to determine differences in access. Who are the under-resourced populations receiving services through the program? Who are identified using data on disparate populations? And so what we're looking at is to see what are the changes, what types of services are being used by under-resourced populations, and how do they vary in type and dosage, and by what under-resourced population. And is it acceptable, affordable, accessible, and available? And then the outcomes is how do these vary by under-resourced populations? And so typically we always use the white population as the reference population, but we can certainly use African Americans as the reference populations. If we're looking at Hispanics, we can look at Hispanics and look at the Native Americans as the reference populations. We don't have to use the white population to really drill down to look at disparities and equities and issues of such. So that's me, and that's how I'll start off the conversation. I'll pass it on to Tim. What are your thoughts?
Can you rephrase the question, Dr. Roary? Sorry, I was busy in the chat.
That's okay. That's good that you were in the chat. So Ingrid posed the question, so I'll put it back on her. But
thank you.
We were talking about kind of the ways that we have almost operationalized racism.
Yeah, so I know here in the region, Taylor and I kind of stood up this program that we've actually since have worked with Dr. Roary on. It's the DIPS initiative. And what that does is it really brings forward the people that are working in the community serving, BIPOC populations who are typically underfunded. And we really want to amplify them in front of funders and, give some funding opportunities, because these organizations are often smaller. They're, trying to get as much money as they can, and they're often not able to receive the funds from the state or from philanthropic opportunities. So what we did is we brought together in a virtual forum, and we had them display their services and what they're doing to the populations that they serve. And it really helps amplify the conversation. And like you said, operationalize what's going on as far as equity. And Taylor, if you want to touch more upon the DIPS initiative that we did, that would be great. Thank you.
Yeah, thank you, Tim. You are an extension of me, but yeah, we wanted to give voice to community-based organizations who are often unheard, unseen, underserved. And we worked extensively with Dr. Roary to elevate that work. And she's brought it national to make a national reach for other CBOs who are in the same boat. Federal resources can only go so far, but we need to work really closely with our state partners, because that's who gets the brunt of our funding. And we need to see diversity among our grantees. Dr. Roary just showed you deplorable, really painful data. But we have the data, and now we have money. But it seems like the more money we have, the more problems we have, and there is a disconnect somewhere. And I'm ready, willing, and able, and have been to get to the root of that problem.
Thank you so much. And this is a panel discussion. So if others want to weigh in, if you'd like to weigh in via the chat or using the raise your hand feature, and of course our panelists can certainly unmute themselves. I would like us to also too in this space, particularly to put on our kind of recovery focused lens and really think about the ways that we can promote policies that are consistent with that recovery philosophy, you know, kind of recognizing the problems with stigmatizing language or how attitudes might impede effective treatment.
Thank you, Ingrid, for that. I wanted to ask Dr. Isom. I'm sorry, I'm not able to see if somebody else raised their hand, and I cannot. My signal is very weak. But I'm wondering if Dr. Isom would like to respond also to the data presentation and help us connect these, because those pieces are all really together, and it's really what's going to be informing our work moving forward.
Yeah, thank you, Maria. I actually, it's interesting that y'all brought up the dips. And I'm looking forward to watching the video that you all have on the website. I am an early career psychiatrist. I very recently was exposed to the understandings that we have that are more mainstream in psychiatry about what our roles should be as psychiatrists and how we can be useful to people. And I've also been existing in a space that's very stereotypical. So I'm in a federally qualified health center in my office. People are coming to my office, or, you know, I'm calling them on the phone to have conversations, and I'm serving as like a, you know, an expert consultant, however that's constructed. And I don't think that that's going to actually change the numbers dramatically at all. And I've been thinking about and kind of trying to unlearn and learn other ways of approaching, other ways of using what I have learned from my training in collaboration with community members. And one of the articles that came out, I think it was last week or the week before, and the New York Post, the New York Times, I think it was the New York Times, was about a Black football player who could not find a therapist that could understand their urban and racialized experiences. So they went to become a social worker themselves. And they've actually partnered with a psychologist and created this program to address the unmet needs within Columbia Heights, which is a neighborhood of Washington, D.C. And the program is called In the Streets. And if you, I will drop the link, but if you go to the website, it was really cool looking at how they formulated the problem, their theory of change. And I wish I could show the slide, but you can see it on the website. And it's a formulation that I may see in like certain spaces in my training us have a discussion about as psychiatrists, but often not so much. So they essentially have in this image articulated what are people navigating, and that's systemic violence and oppression, specifically focused on the Black community. And then how can they interrupt that? And what are the root causes that they might be able to address? And they are very much focusing their intervention around leveraging role models and community leaders. So part of their intervention is like offering holistic care approaches to the community, like yoga and things like that. But a huge part of it is people like psychologists and other mental health professionals training community members to themselves intervene in a number of different ways. And that allows them to have support networks within their community, but also allows them to serve as role models for others. So I personally am also thinking and trying to expand my understanding of how outside of an actual clinic, we could be more useful to people. And I think that's a very equity sort of conversation, because one part of the framework is thinking about our relationship with community members and how it might be, or very much often is, hierarchical, and power is not really shared in our relationships. So one way of switching that around would be stepping outside of the clinic and collaborating with, offering our expertise to, and then working alongside organizations like the ones that you were talking about, which is a lot different than asking people to come into the office. So those are just some thoughts. Would love to hear from people in the chat and others on the panel what they think about that. But that is where I am interested in moving forward as I progress in my career, is just really thinking about what that could look like.
Oh, that's
Dr.
awesome. Go for it.
I was just going to say, that's incredible, the article. Thank you for raising that and bringing it to our attention. There are some Black barbershops who have adopted this model and is looking to get some mental health counseling to be more value added and more supportive of their clients that come in. Because as we know, hairdressers and barbershops are sometimes places that are safe where you're able to sit with like-minded individuals and share hardship and pain in cultural activities that one another can understand. And so, yeah, I commend that work. And we know that there is some innovations happening across the country with various spaces. So thanks for sharing that.
I'll just hop in really quickly because I would really love to hear from the audience, but meet them where they are. That's all we have to do. You're gonna have to leave that office. And I learned this back in 1992 at Johns Hopkins University. We were recruiting young African-American men to a high blood pressure study, and we were struggling with recruitment. And so I didn't even know anything about research really. So I was like, well, maybe if I can just ask a few people, and they called that a focus group. I invited some of the young men that we were trying to recruit to come in and talk to me about what would get them to the clinic to focus on their blood pressure. And you will not be blown away by this when I tell you that they told us, well, if you would have some food and a TV in the waiting room and some beautiful ladies to wait on us, we'll come to the clinic. And sure enough, my first unofficial research study proved to be true. And guess what? We got the folks in. And so it was 309. We were only supposed to recruit 250. It was 309 participants. And we were able to follow every last one of them for over 10 years, and some to their own deaths, unfortunately. So going where people are, you got to leave the office. I promise you it works.
Great, thank you all. Unless there are other comments, there are actually a few questions in the chat. So I'll read those and let's see if we can have those addressed by our panelists. Heather has a very specific race data question. She's asking how to address challenges to disparity analysis when the number of individuals in non-white populations are small. Therefore, it's not always possible to show statistically significant differences between white and non-white populations on mental health outcomes.
I'm happy to jump in, and then Jessica can back me up. But there's something called the modified Kilman filter, and it's a statistical technique that's been out for a really long time that helps you to work with small populations. One of my frustrations when I first got into the field was Asian Americans. Oh, the population or the N is too small. So the sample size is too small to detect or determine any differences or trends or statistical or clinical significance. No longer an excuse. There are definitely different statistical techniques that will help you manipulate the data to show that even with the population, say their population is at 500 and the other population is at 100,000. The population that's at 500 at 100,000 can actually equalize from the different statistical techniques that are out now. So we're past that, and tell people they can't use that excuse any longer. And I'll put the link in the box. Thank you for your question. Dr. Jessica, if you want to add, go for it.
One thing I am is very transparent, and I am not a statistician. So I'll defer to the expertise within your answer and just
go. Okay, good. I wanted you to challenge me and say, Mary, that's wrong. I'm teasing.
Well, we're at the point now where we typically would like to have, kind of 15 minutes available for Q&A. Are there any other questions or comments that people would like to weigh in via the chat, or by unmuting yourself or asking to raise your hand? We've solved world peace. No questions? Okay. Well, we are here to support and assist. If you want to go to the next slide, Vanessa, we can kind of take a look at what's coming in our next series. So this is our series through August of 2022. You experienced our inaugural session here, but we kind of have divided this into quarters. So our next session will be around the impact of implicit bias on BIPOC populations, and that's in January. Our February event is focusing on engaging in crucial equity conversations. In March, we'll be looking at understanding organizational implicit bias and its impact on BIPOC populations. Quarter 2 is kind of a focus on transformational leadership and change, as well as building practical guidance on allyship, and then really integrating diversity, equity, and inclusion into everyday operations. And then finally, we'll wrap up with the importance of BIPOC mental health professionals, which is critical, and then engaging allies, nurturing relationships for lasting change. So I invite you to stay posted for program updates. This is actually kind of a learning community, so we hope that you can join us and stay posted for program updates as well as registration information. And with that, I'll let Vanessa close us out. Thank you.
Thanks again for joining today's webinar. Attendees who provided their email address will receive a video of today's webinar, along with the presentation slides 24 hours after the close of the webinar. We are also required to evaluate our training and technical assistance efforts. You can use the link that's going to be posted in the chat, but it will also be available once this webinar closes out. And for more information, you can always go to our website. Thank you.
Vanessa, I would like to thank the presenters. In addition to the announcements, this was absolutely amazing. We really are honored by your presence. Our hearts are filled with gratitude, and we really, really hope that we can continue this work. And you have just made a tremendous effort with all this wonderful conversation. So thank you so much for everybody, Tim, Jessica, everybody on the call, Taylor, Dr. Roary, for being with us today. And for our amazing team, Janam, Vanessa, and Ingrid, kudos for everybody. And thank you so much for joining us today.
Thank you all. And we're fortunate